Hi, I'm the director for Common Knowledge Trust, and I was very privileged in the early 1970s to work with hundreds of fathers and mothers who developed birth skills. Simple as that, birth skills for their birth. Because there's a truth. We are only interested in our own birth. We're not interested in anybody else's. Oh, we may get together in groups and talk about that and praise and blah, 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 but we're only interested in our own birth. It's as simple as that. So in 1970, when I gave birth, I want you to know that the words normal, natural, and physiological meant something different than what happened when I gave birth last in 1982. There had been this profound shift. Now, you could see it coming, but it wasn't entirely entrenched in the way people conversed about childbirth. So when I gave birth in 1970 in the United States, I and millions of families from the 60s to the mid 70s attended the first ever childbirth preparation classes, which were entirely skills based, absolutely skills based, Lamaze and the Bradley method. And those two doctors and another one, Grantley Dick Reed, whose classes were taught in New Zealand, where I've lived for 25 years, they believed that the word normal and natural actually should be associated to what was becoming a term, which was low risk, which then put you versus high risk. So prior to that, and across the globe, throughout time, throughout humanity, normal, natural, and physiological is just what pregnancy and birth is. It's normal, it's natural, it's physiological. Whether women are healthy or sick, whether they like the experience or hate it, whether they suffer or feel great, whether they have risks, whether those risks become problems, and whether those problems become tragedies. So when women today are talking about their breech baby, they really are talking about their breech baby. What are they going to do about their breech baby? We want to know about our birth. Is our breech baby normal? Yes, it's normal. It's normal to have twins. It's normal to be 5 feet. It's normal to have health issues. It's normal to live where there's a famine or a war or a natural disaster. It's normal. Being a solo mom is normal. Being a woman with 20 children is normal. Anything is normal, and it's natural, right? Certainly a cesarean isn't physiological, but our body is responding to pregnancy and birth in the same manner. It's our mind knows that we're going to have a non-laboring cesarean. Our body doesn't know that. So in 1970, when there was only a 4.5% cesarean rate, we all labored, whether we had risks or not, whether we had breech babies or not, whether we had twins or not, whether we had diabetes or not, whether we were Rh negative or not, whatever, we just labored because the medical profession wasn't sophisticated enough to really assess what risks might become problems. And modern women were not as risk averse as they became. And they became risk averse between my first child and my last child in 1982. That was quite extraordinary. And a large part of it had to do with the fact that we started to wear bikinis. So we need to, now you're going to ask, why was that important? Because cesareans in 1970 were major abdominal surgery. We got cut from our pubic bone to our navel. We were given a general anesthetic. Our babies often normally reacted to the general anesthetic and had some difficulty being resuscitated. We had trouble recovering. And many of us wanted to try to have a vaginal birth after a cesarean, and it was risky. It was normally and naturally and physiologically risky because when they cut the uterine muscles like this and our uterus contracts in labor, it puts a lot of stress not on the scar, but on the scar tissue around it. And women started to wear bikinis. And what did we want? We didn't want a scar left on our belly. So the medical profession came up with the bikini cut. They didn't invent that name. They didn't do it so we could wear bikinis. They did it in response to our demands that they do something different, coupled with the fact that we wanted to try to have vaginal births after cesareans. And this has led to not the cascade of interventions, but the cascade of us as consumers wanting to reduce the risks to our babies, including our breech babies. That is why on the social media platforms, so many pregnant women individually are doing so many things to try to turn their baby into what they consider to be a normal position, which is head down. I want you to know, in the 50 years that I've been involved in this, I've read some amazing things. And I think it was in the 1800s. There was a Dutch midwife who considered it wasn't normal for children to be born head down because humans walk on their feet after birth. So she used to do internal versions and turn every head down baby into a footling breech delivery. She considered that normal. I don't know. I just am overwhelmed by how many ways we interpret the word normal, natural, and physiological. So the way that I've always interpreted it, and as the director of the trust and is working with hundreds and now tens of thousands of people, it's whatever might happen could happen. And it may happen. So the question is, what do we do about normal when it doesn't mean what it's now has been shifted to mean since the 1980s, when the natural birth movement and the home birth midwifery movement joined together and we began to have this global conversation. They started to differentiate between low risk and high risk. And that's what Lamaze and Bradley and Grantley Dick Reed had started to do when they developed their skills. They targeted those skills to low risk women who, if they use skills, could have pain-free natural births without medical interventions. But that makes a huge number of assumptions, right? And I was fortunate enough to hear a woman, Marjorie Tu, she was a UK researcher, who did research on risks. And she determined that no matter the risks, there is zero correlation, really, between how easy it is for a baby to get out of a body or how well women cope. So you need to understand that when we're dealing with breech births, a baby in a breech position is normal. It is normal that your baby delivers in a breech position. If you want to try to turn your baby into a head down position, that's your choice. And if you do that, that should be your business. And if you achieve that and you have a good outcome, then you may make the correlation that my doing that lowered the risk, which may or may not be actually accurate. And if you have a poor outcome with a baby that you turned, then you will have feelings about that as well. So when we're talking about normal, natural, and physiological around childbirth, and particularly around breech births, it is normal that your baby is in a breech position. It is normal for you to birth a breech baby. It is normal that breech babies have some risks associated with it. Breech babies are not the only pregnancy or birth that has associated risks. There are no generalized risks. A head-down baby can have risks associated to it, which have, honestly, in 50 years, I have heard stories of where there are poor outcomes. And those poor outcomes have been in all sorts of birth circumstances, from cords that have a knot in it, to cords that are wrapped around necks, to delays in second stage, to all sorts of things. Uterine ruptures, placentas that detach. It's normal and natural and physiological for those things to happen. They're can be tragedies. And what's important to know is there's a distinction within us in how we approach what's normal, natural, and physiological. I'm sitting here right now. It is normal, natural, and physiological that I could just suffer a heart attack and drop dead. Honestly, you too, right? You could get in a car to just drive down the street and some kid can run in front of you and you can hit it and kill it, right? We cannot control the future. What we can control is our response to what happens to us. And that's why 50 years later, I'm still talking about this. So when normal, natural, and physiological in 1970 meant anything and everything, and things might happen, to when I gave birth in 1982, when the message was normal, natural, and physiological meant low risk, that then led to the conversation you're having now as a breech mom. You believe in that. You believe that normal, natural, and physiological really means low risk. So you're doing everything you can to try to get your baby to turn, to become low risk. That's a belief that comes from an idea. Okay? That idea is not being questioned, right? And that leads to things. So right now in the breech conversation, it's leading to an increased training in providers that will help at a breech birth. And that's wonderful. However, it leaves out us, right? Okay? What a provider does to or for us also is determined by what we do for ourselves and also to support their efforts to help us. So in the 70s, when I started to work with hundreds of families and we were confronted with this normal, natural, physiological, the beginning of the discussion of what that meant and how we were going to all respond to this, the families that developed skills just said this: I am pregnant with my baby and I want to have something that I can do for myself so that I can feel proactive in doing this. I may do all these other things, but when push comes to shove, I'm going to birth my baby. And during that activity, my partner and I really desperately want to work together more effectively. Fathers were just coming in 1970, Lamaze and Bradley. Bradley was called Husband Coach Childbirth. Fathers were expected to be the coach. Any new system is new. So Lamaze and Bradley were new systems. First time that you had a universal way to approach skills associated to birth, which is an activity. That was admirable. Those skills needed to evolve. So we evolved skills. Then the choice-based system overrode the skills-based system. They didn't travel together. They need to travel together. It's great if you have choices. What happens if you have a lack of choices? What happens if your choices change? What happens if you choose all these things and you don't like any of them? However, you still have to do the activity of birthing your breech baby. And you birth your breech baby, whether you've been able to turn it or not, and you breech your birth baby, whether you're with a care provider who's comfortable with birth that day. Their kid might be sick. They may have been up for 36 hours attending other births. So we develop skills for ourselves and for our breech babies. One of the group of skills that we developed were basically understood and created by the fathers. Because fathers see birth from the outside. We're giving birth to our breech baby and we're focused on that. So we miss a lot. but someone on the outside sees us, and fathers see us. They particularly saw us when their role was to be a birth coach. They stopped seeing us when their role was shifted in the 80s to just support women's choices or to protect the sacred space of labor, which I want to digress for a moment. Women do not have to be safe to give birth. They're birthing all over the world in war, famine, horrible situations. That is misinformation that women have said to one another. The birth hormone oxytocin is not depressed in us just because we're unsafe. We still have to birth our baby, whether we are terrified, whether we are pleasured, whether we suffer, whatever. We cannot reduce birth down to something that we were trying to achieve when in fact we just have to get through it. And the best we can do is to be able to do something for ourselves. So one of the things we did for ourselves with all births, particularly breech babies, particularly twins, for particularly issues like heart problems, kidney problems, bifurcated uteruses, whatever, was that we prepared our body. We didn't try to get our baby to move. We tried to make space in our body so that this big object could come out. And that's what fathers understood. And that's why it's so important that we understand that we share this common body language as women and men. We all blink, we all cough, we can all tighten up our rectum. Men can't see us tighten up our rectum, and we often don't know we're doing it. However, if we have skills not to do it in birth, and the men or others say to us, soften around your rectum, we will do that, just as you just did that right now, because your attention was drawn there. So we prepared our body to try to help our babies move through it more effectively. And that made a huge difference in how our births unfolded. Because even when we cope well, if this big object inside us can't open up the container of our body, it gets delayed. And one of the risks of breech births is the delay in the delivery of the arms and the head. That's the highest risk. So what we learned in preparing our body is that most of us had no idea about what our pelvis was. Pelvis? Hole in our pelvis? If you give people a bony pelvis and say, there's a big hole, where is it? Touch it. Most people will go, I don't know. Where is the top of that pelvis? In your body, in my body, in that man's body. Same place, but most of us aren't aware of it. So if you put your fingers now on the top of your pubic bone, press in, that hole that you see, massive hole that you see, runs from there all the way around to our hips and to our sacrum. That's the inlet of our pelvis. Most of us, by the way, think that our pelvis is sitting like this, right? And so we think that our baby just comes down like that, right? Sometimes you have people who show you, but we just gloss over it, honestly, right? So the baby first has to come into that inlet. We can't feel that, right? Then we have an outlet. Let's skip that mid part. We have an outlet. That outlet's what you're sitting on now. The demarcations of our sit bones and the pubic arch, the inside of the pubic arch where you can feel, put your hand down there and feel it, and the length from there to our tailbone. Those are spaces. That's the space our baby has to move through. The mid part of that can only be felt inside, and we can feel it inside. I can feel it in my body, but I can only feel this very front of that mid-pelvis. Whereas if I sit down or if I lie back and I have someone else put their finger in, they can feel the mid part of that pelvis. And that bony pelvis is almost never symmetrical. Sometimes it's flat, sometimes it's actually like that. Sometimes it's like that and like that, different sides, right? Our baby wants to move through the easiest space. And that bony pelvis is entirely surrounded by inside and out. All of us, all of this parts of us, is all soft tissue. So you can see my shoulders aren't straight. That's soft tissue. Okay? Down there, when I asked you to soften around your rectum, that's soft tissue. So if you tighten your rectum just a little bit, you close off that space. If you tighten up inside your pelvis, you close off your space, which then goes back to what I was taught in 1970 by women, which was to do pelvic floor and Kegel exercises. Hold back my pee, to strengthen my pelvic floor, with the idea that a strong pelvic floor would help me push out my baby. And that is nuts and inaccurate. Tighten up down there. This is what guys get. That's coming through us. If we're tight, how easy is it for that to open us up? Not as tight. So stop doing pelvic floor exercises from 24 weeks. Pick them up after pregnancy. Do them the rest of your life. But from 24 weeks onward, we learn to open, to soften, to make mobile, to create space. And we had to know what our space was like for our breech baby. Not anyone else's space, our space. So when I watch breech births videos and when I listen to breech stories, you will hear those women who have an ample pelvis by dimension and have a baby that fits into that pelvis easily say it was a piece of cake. What we don't hear about are those women having breech babies where this is not so simple. What percent of women have ample pelvises? About 50%. So the other 50% have variations. And what's an ample pelvis? Usually the dimension between the bones you sit on is about equal to the dimension of the front to back. Okay? It has a medical term. It's called a gynecoid pelvis. Go figure. But if we map that and we can then feel our baby, we know in our mind, yep, I got a sort of a small baby. This baby moves around a lot. Oh no, I got a big baby. I can tell it's a big baby. It's just compacted in there, right? Nothing to do with height, right? You can have tiny women who have very ample pelvises. My doctor told me I could get a freight train through it. Well. Okay, tall women, those women with childbearing hips, they may not have an ample pelvis. The outside of us has nothing to do with the inside. So when you talk about normal and natural, our pelvis is normally and naturally whatever it is, and it's physiological. However, if we have a narrow dimension, then it may be harder for our baby to normally and naturally fit through us. So we have to use those words judiciously and understand them. And when it comes to a breech baby, each of us wants to have the safest birth possible. And before I leave, I want to maybe I won't. Save it for another day. So just remember, normal, natural, and physiological, in its dictionary definition, and in its definition up until really the mid-1970s, meant anything, right? Anything. And anything might happen. But there are no general risks. So you may have a breech baby with other risk factors, or you may have a head down baby with other risk factors. And we'll talk about risk factors in another video. So what you want to understand is if you can prepare your body, if you can create space in your pelvis, if you can know what your bony structure is like and be able to have control over allowing it to open up, and if you can or cannot turn your baby, and if you can or cannot find a care provider who can help you with a breech birth, and if all of those things align so that that care provider is there and your birth doesn't go on, and all those variables that can happen because there's no way to know what your birth's going to be like and babies don't come to plan, then you just need to know that at the baseline of everything, the more skilled you are, the more you can open up for your baby, the more you reduce or prevent the associated risks of a breech birth. And that has to be good for everybody. It has to be good for your baby, has to be good for you, has to be good for the care providers. And it has to be good for the conversation we have with one another, which right now is focused on your choices and has no conversation about becoming skilled. As this one young woman just said, is there was nothing in her mindset that said birth is an activity. First of all, she had no mindset that it was an activity she had to do, and she had no mindset that if she had skills, she might do that activity better. That's what we're trying to convey as a trust. Become skilled for your normal, natural, and physiological breech birth. If you have a cesarean, your body and your hormones are still having a normal, natural birth. Use skills to work through the activity of birthing your baby because you got pregnant to have a baby. Do not become passive. Do not become a lump on a log. You are giving birth to your baby via the activity of just driving to the hospital, being prepped, and during surgery. Honor your relationship as a mother and father to work through the activity of birthing your baby, even if you have a surgical birth. Wow, I usually stop at 20 minutes. I'm going to stop now. So, breech is normal. Full stop.